I'm going to start with Leigh Anne. So Leigh Anne Burns is a retiree from LSU New Orleans. She's now in private practice, and she's a nutritionist and dietitian. We have Dr. Helen Te here, who is a hepatologist at the University of Chicago. We have Dr. Jaydira del Rivero, who is a medical oncologist at the National Institutes of Health. We have Dr. Tessa Balach, who is a orthopedic surgeon at the University of Chicago. And then last but not least, we have Dr. Erik Nakakura, who is a surgical oncologist at UCSF. So welcome all of you. I'm really excited to have you here for the next 20 to 25 minutes. We'll answer some more questions that were asked by our patients throughout the day, and that specifically relate to the topics that you have talked about throughout the day. So let's go right into this. Let's start with Dr. Balach. So we have a question about which modality, surgery versus radiation oncology, is preferred for bone disease that is symptomatic.
It's a great question, and one that I spend a lot of time talking with my patients about. They're really two separate treatments used for different reasons, although used complementary in many situations. We think of radiation being applied to bone tumors from neuroendocrine tumors that are painful. We use the radiation to sort of attack that tumor that's growing in the bone. Radiation, though, on the other hand, doesn't help the structure or the strength of the bone. And sometimes bone tumors can eat away at the bone so much that it puts them at risk for breaking. And that's where surgery comes in. Our goal with surgery is to help with pain that's coming from the bone getting weak. So it reinforces the structure of the bone. And certainly if the bone is broken, we often have to do surgery a lot of times. So really the goal of surgery is to help with the strength and the physical structure of the bone, where radiation helps us actually kill the tumor cells that are growing in the bone. So we often use them together, but that's how I like to think of them in two separate categories.
Great. Is there a certain strategy that you use where you tell your patients, should we do surgery first versus radiation first? What should come first? So meaning if you've had a tumor that was operated on and it came back, can you still radiate it? Or vice versa, if you've had a bone tumor that was radiated, can you still do an operation on it?
Yes to both of those things. So oftentimes when we think about using surgery to treat a bone tumor, we do the surgery and then coordinate with our radiation colleagues to do radiation right after surgery to treat that. So it gets kind of a 1-2 punch, both surgery for the structure and then radiation to treat the tumor. Sometimes even after radiation, that tumor can continue to grow in the bone. And then the structure part is what we have to take care of. And we can easily do surgery even if radiation has always been done.
Great. Fantastic. Thank you. One more question that we had related to bone disease, and I don't know, like Dr. Balach, if you could answer that, but the question that was asked was, does like aspirin and other NSAIDs help against bone disease? So how do you manage the pain in and around surgery and after surgery when it comes to bone metastases?
So we use a number of different pain medications in and around surgery. So maybe even before surgery in bone metastases that are painful, we can use things like Tylenol at times, over-the-counter anti-inflammatories, and then we get into stronger pain medications if we need to. And all of that is really tailored to each patient based on the degree of pain, what systemic therapy they're on, because sometimes they're on treatments that make us pull back or want to use a different medication preferentially. So it is something that's tailored, but we have a nice big selection of medicines to pick from to help treat pain. Great.
Thank you very much. All right, let's move on to Dr. Nakakura. There's a question here about a patient that was asking, does diabetes increase after surgery for pancreatic neuroendocrine tumor, especially if you only remove the tail of the pancreas?
That's a good question. I'd say in general, If you're just removing a part of the pancreas, whether it's the left side of the pancreas or the right side of the pancreas, most patients do not become diabetic. There are some folks that are on the fence, like they're carefully watching their diet. They're sort of borderline diabetic. In that situation, surgery may tip them over the edge. But in general, taking out a neuroendocrine tumor in the pancreas does not make someone diabetic.
Great. Thank you very much. Let's move on to Leigh Anne. So there's a question here, Leigh Anne, about nutrition. There's actually a couple of them. So one patient is asking, let me see, I gotta put it, can food triggers ever go away with any particular treatment? So is your experience that as patients that have food triggers and get treated over time, do they actually tend to get better, or does that sort of stay the same over time?
No, if a treatment such as a surgery or PRRT actually has decreased the tumor over expression of hormones and the tumor bulk, many times we can reset that and kind of reset their symptoms as well. So yes, it can change during treatment times, depending on what's the overexpression or the expression of hormones from the tumor. So that is, we do see that. And sometimes when we work with a diet and we alter things, that the body can adjust to certain foods that they might not have tolerated over time. And we see that sometimes even with just symptomatic things like gas and irritability as well. So we just kind of take everything down and start again and just work a diet up. But yes, it can change. That's the answer. Sometimes it sure can change.
Great. And there were at least one or two questions about sugars. In your experience, Leigh Anne, does it matter if you eat a lot of sugar? Does that trigger symptoms? Or even worse, are these actually sugar-driven tumors? So do you tell your patients to stay away from sugars because the tumors could grow more rapidly?
Now, I don't tell them that because it can make them grow more rapidly, because I don't think we've got that proven in neuroendocrine in research yet. But what it does is increase the motility of the GI tract. We see that often behind Whipple's and gastric surgeries for sure, also with the small bowel surgeries. So the concentration and the osmolality, this is going to cause what we used to kind of in gastric, we call it a dumping syndrome, but a real rapid emptying of the GI tract, and that's going to increase symptoms. Also, one of the symptoms that's real common is fatigue. And when you drink concentrated sweets, it's going to make, even in a normal patient, will make that blood sugars go up higher than normal. They're going to fall faster from the insulin release, and it increases fatigue syndrome. So one of the things that we, the high loads of sugar can also play a part with that as well. And we may see some other reasons, but we usually, when you're looking at the label, when we talk about concentrated sweets, we try to keep that on the label 12, kind of is the magic number. So we try to keep the sugars down below 12 or less.
Great. So as usual, a fine balance is what the human body needs. Fantastic. So let's move on to the next question. This is a question for Dr. Te. What about liver transplant in NETs? What's your experience with it? Should we use it frequently? Any comments about that?
As we all know, liver transplants are pretty big processes to go through, and availability of donors is not necessarily so widespread. So we do tailor the liver transplant indication to the patients who will most likely be successful. Now, majority of these patients will end up with good survival, but more than half of them will have recurrences after 5 years. And so it's not going to be a complete cure, but simply another way of prolonging survival with still some capacity to control the disease. And so liver transplant is feasible and most likely to be successful if the neuroendocrine tumor is only in the liver by the time the transplant is done. There's no other extrahepatic disease present. And also if the primary tumor was within the confines of the drainage of the portal venous system, meaning from the intestines mostly, the pancreas, nothing from the esophagus or the rectum or the lungs or the adrenals or thyroid or any other organs. So that would be a very stringent criteria for liver transplant. And then there's other things like it should be well differentiated and should have stability for 6 months. But yes, it can be done.
Okay. Do you worry about immunosuppression after a transplant? And do we know how this affects really like recovery in these tumors?
Well, any tumor that is indicate as an indication for transplant would always have a risk for recurrence. It's just a matter of how high that risk is. And for neuroendocrine tumor, as I mentioned, it certainly is expected to recur. So we do have a strategy to try and decrease the risk of recurrence. We just don't yet know if this is really going to make a difference, but there's certain immunosuppression that also have anti-cancer properties, anti-oncogenic properties. And so we tend to go to those kinds of immunosuppression in this setting.
Perfect. Let me switch right over to Dr. Nakakura. What's your experience for liver transplant at UCSF? And where's the difference between should I transplant someone or should I debulk someone? And that comes also to the third question, which is when we talk about liver tumor burden, how does it matter? How does that play in your role to be able to say, I'm going to bring somebody to the operating room and actually debulk someone versus I can't do it. Maybe if all the systemic therapies I use, a transplant would be a good option.
Yeah, those are really great questions. I think the common theme of all these very complex situations is the importance of getting the whole team, the whole multidisciplinary team to weigh in. It's not any one person making the decision. It's the team consensus. I can say that every patient is a case-by-case basis, and that's why you really need to come up with an individualized plan for each patient. In most situations, a tumor board comes with at least 3 recommendations that they're all pretty good, reasonable options, and it comes down to patient preference and also patient particular circumstances that kind of dictate which one of those 3 recommendations rises to the top. Regarding transplantation, certainly that's something that's always as an option, something to consider. I think because there's so many different modalities short of transplantation, such as liver-directed therapy, PRRT, surgery, and systemic options, although transplant is an option, it's at least in my experience, it's very infrequently done. At UCSF, I think when I asked our transplant surgeons, I think maybe only 1 or 2 have been done in memory. I don't know what's the experience in Chicago for transplant for neuroendocrine tumors.
I think it's very similar. I think we've done, right, Dr. Te, maybe a few over the last 2 years, I think. I don't know exactly the number. You probably know better. But
Very few. It's probably within 2 or 3 in the last several years. But it certainly is just, I think, something that people are getting more comfortable with at this point.
And maybe something, as we probably heard in the news now, that there are newer ways to potentially generate organs, because I think organ shortage has been a real problem, right, for transplantation in general. And so, perhaps if we in the future can generate some organs, that are not that like immunogenic, but have like criteria or like characteristics of the patients and grow them, for example, in pigs, then maybe we'll get a much larger base and maybe this will be a better option, right? So I think the future will show us where things are going and where we're going to go with this.
Yeah, but certainly I would say transplant is almost like the last resort.
Right.
When you really can no longer do surgery and you've done all your treatment that you can do, and yet you still see residual tumors in both lobes.
Right. And also important to say that the grade matters, right? So if you have a highly rapidly growing tumor, transplantation would not be an option, obviously, right? Because these tumors recur quicker than the transplant organ goes in. So I think that's an important point. Sorry, you're saying something else?
I was going to say that's always the discussion is, when do you decide to do it? Do you do it earlier or do you do it later, right? And a lot of pros and cons for both options. I think someone asked about tumor bulk and what makes you decide to do surgery. I think this is another excellent thing about why multidisciplinary input is so critical, because as a patient, imagine that you may have a very small tumor but in a very difficult location, or you can have a very large tumor in a very favorable location. You see how the size of the tumor may help or not help, but location may trump size. And then if you start adding the complexity of you have, some small tumors and large tumors and a mixture of good sites or bad sites and one side versus the other side, you can see how complex the decision making can get. And this is why I think you really need to go to a place that sees a lot of these and can appreciate the sort of nuances of all those things I mentioned. But there's not a simple rule like saying number of tumors, size of tumors, side of tumors, because all those very complex issues interact.
I think that's a really good point. And I think it depends, like you said, on a lot of things, including like the experience of the people like that are part of your team, the experience of the surgeons, et cetera, the experience of the radiologists, who sometimes can really do amazing things in a much less invasive way than we could with surgery. So I think that's a really, really good point. The next question is going to be for Dr. Del Rivero. How common is it for a well-differentiated neuroendocrine tumor to mutate into a poorly differentiated NET?
Yeah. Thank you so much for that question, and thank you so much for having me here today. So that's a very good question. And in my experience, I don't see that much of the differentiation. I have seen over time, like over a long period of time, I have to say over a few years, that the tumors sometimes start to behaving a little bit differently in the sense that we start seeing a more of a rapidly growing disease and a well-differentiated tumor. And in that situation, that's when I usually recommend doing a biopsy, because I have seen that sometimes they differentiate a more aggressive behavior. And for me, that's important to learn, because that can also guide me what will be the best treatment option in those situations as well.
That's a great advice. And let's stick with you. And a question that's sort of maybe indirectly related to that. Is it possible to revert the mutated NET cell back to behaving properly? In other words, to fix the wrong acting DNA of these mutated cells?
Yes, I think that's not a question that nobody knows in a way, unless, any of the panelists here may know that answer. I think once we see that there is a increased mutation on these tumors, it's very difficult to reverse in a way. But again, there is so much that we still need to learn about tumor biology overall to help us understand. And that is definitely a research question and something that we need to learn more.
Fantastic. Dr. Te, a question that came into my mind just while we're talking about liver transplant and surgery with Dr. Nakakura. Is there anything you recommend as a hepatologist that patients do in general to keep their liver healthy? So is there anything that you would say, if I have to undergo surgery, or even if I don't, is there anything in particular that I should try to avoid, or how do I keep my liver healthy so it can undergo, liver-directed therapies or surgery or even a transplant, which I guess in a transplant doesn't, make that much of a difference because you take the old one out and you replace it. But what about these other scenarios?
Yeah, that's really important to try and see how you can make your best, the best health of your liver to combat all these treatable, treatment, but destructive, modalities, right? So I think that the easy answer, easy for me to say, may not be easy for people to do, is alcohol. That really is the one thing that you could stay away from that would keep the liver from having any alcohol-related injury that may potentially impair the regeneration of the liver. And the second thing would be try to stay healthy and avoid having a fatty liver. A fatty liver is usually a result of three things: excess weight, diabetes, and really high triglycerides or cholesterol. So if you have diabetes or high cholesterol, you may want to control that really, really well to remove the excess fat that causes in the liver, and then the excess weight, take care of that if you can, to decrease the fat in the liver and allow regeneration again to do its job really well.
Fantastic. Thank you so much. I have, let's see here, another question. I think that's a really interesting one. for Dr. Jaydira again. So I would love to hear more about what options exist in personalized medicine, including personalized vaccines or mutation targeting therapy. So I think what the patient is referring to is a talk we heard this morning about, when you do molecular profiling and you do get some specific mutations, in your tumor that are targetable. How experienced are we with NETs? And how's the NET research going into that field? And how do you think the future is going to pan out for that?
Oh, wow. Great question. And I think there's two, I would just want to answer into two different ways. One, let's discuss about vaccine, and then the second one about targeted therapies. So in terms of the field of vaccine for neuroendocrine tumors, it's still a very evolving area and field that we're trying to study. So I have to mention that there is a study that is run by Dr. Ranuka Iyer, and it's a vaccine called Survive, and a surviving long peptide vaccine, and that's specifically for neuroendocrine tumors. Actually, the initial study was funded also by the NETRF, and it's very exciting to learn about what is the efficacy of this vaccine in neuroendocrine tumors. And the purpose of doing that is to stimulate the immune system to then determine if that could then kill the cancer cells. But again, there is an evolving area. We still don't know where it's going to fall into the treatment algorithm for neuroendocrine tumors. But the fact that we have in these treatment modalities that can enhance the immune system to kill the cancer is something that is definitely an exciting area to study in the field of not only neuroendocrine tumors, but as well as for other cancers as well. So far, there is no vaccine that is approved for neuroendocrine tumors, so that's still into studies and clinical studies. And my advice in terms of the vaccine is to then be enrolled in clinical studies to determine what will be the efficacy of this vaccine, especially for neuroendocrine tumors. Now, in terms of molecular studies or targeted therapies for neuroendocrine tumors, I think that's also an evolving field as well. It's not like lung cancer that we can find a molecular target that we can treat, but the neuroendocrine tumors, we're still learning about that. So far until today, there is no specific mutation that we can target with treatment, especially for the small bowel neuroendocrine tumors. There is not that many mutations. We actually think that it's more of a genomically blend type of tumor compared to the pancreas neuroendocrine tumors. Pancreas neuroendocrine tumors, there are different mutations that we have understand, and we're trying to then, based on that biology and the molecular panel of these neuroendocrine tumors, we then trying to target with certain treatments, but it's also an evolving field as well. So maybe a year from now, 2 years from now, we'll have more specific answer about that, but definitely a very good question, a very interesting question, and so much that we need to learn about neuroendocrine tumors as well to help us understand about it.
Great, thank you very much. Dr. Nakakura, what do you think about genomic profiling for PNETs? Do you do it routinely in your practice, or you just do it when patients progress and they run out of options? And in your experience, has it changed the management at all for patients?
Yeah, I can tell you that my colleague, Dr. Emily Bergslin at UCSF, who's a medical oncologist, routinely profiles patients with advanced disease. I think this is an evolving field, and I think the more data and information we collect over time might inform us down the line. But I think it is an evolving field, and a very promising one in that.
Great, fantastic. Thank you very much for all of your participation. It was really great to see all of you. I hope at some point we can do this again in person. The last 2 meetings have been virtual. So thank you to all our patients for being part of this day. I hope that you learned a lot. I think we all had really, really good speakers and really, really good talks today. And I'm going to hand it back to the studio at this point. And thank you very much for all of you to taking the time this weekend to spend the time with us.
Thank you for having me.